Good afternoon from Ireland, everybody. My name is Dara Connolly. It is my great pleasure to welcome you to this webinar about the co-administration of flu vaccines and COVID-19 and leveraging community pharmacies in that process. If we could have the next slide, please. I am really proud to speak to you. I don't have a fancy background, but I'm really proud to speak to you from my community pharmacy in a very small town on the southeast coast of Ireland. And the reason why I'm proud to do that from this consultation room is I have been able to, over the last 10 years, vaccinate probably about 5,000 different instances of people for flu vaccinations, but also more importantly, in a way, to help fight the spread of COVID-19. I've been lucky enough to be able to vaccinate my community here in my small town and play my small part in helping to get a really high figure of vaccination here in the Republic of Ireland. I am the president of the community pharmacy section in FIP, and it's really important to us to advocate that people can have access to lots and lots of world-class services through their community pharmacies and through their community pharmacists and the teams that they lead. And today, what we're talking about with really fantastic people presenting and then talking to us in our panel discussion from questions that are going to come from around the world. I'm really excited about this. As a small aside from the community pharmacy section, I'd love if everybody could take the time and have a look at our vision for Community Pharmacy 2025, because one of the 4 key pillars of what we do as community pharmacists is to be able to administer medicines, as well as review, as well as prescribe, and as well as dispense. So without further ado, if we could move on to the next slide, I'll just do some housekeeping. So the webinar is being recorded and live streamed via YouTube. The recording will be available on our website, events@fip.org. And I'll be reminding you about that later as well. You may ask questions, but do that through the question box provided, and you're welcome to provide feedback, and we welcome feedback to webinars@fip.org. And then really importantly, because we're a family and we want more and more people to have the experience of being in FIP, please think about becoming a member of FIP, and you will be able to do that through the FIP.org website. So we move on to our next slide. Now, I would then like to take the opportunity to thank Sanofi for supporting this online event through unrestricted funds. Right, we have the overview of who we have today. So I will be introducing those people individually as the time comes. But like I said at the introduction, I'm really excited to have so many really interesting speakers who bring a wealth of knowledge from the different areas that we're going to try to draw together today. So they're Mitch, Paula, Lisa, Sham, and Ruben, but we'll get to them individually as time goes by. So as we go then, it's my introduction. The introduction of the pharmacy-based vaccine co-administration will be a really interesting presentation by Mitch. We then have the presentation of the guidelines, and they are the FIP guidelines on COVID-19 and flu co-administration. They'll come from Ruben, who works with FIP, and that will be a recorded presentation. And then we have the questions and answers, which is the panel discussion with Sham, Lisa, Paula, and Mitch. And then we'll have some closing remarks and we'll try and draw things up into a conclusion. So let's move on. At the end of the event, the participants should be able to understand the benefits of the vaccine and co-administration, recognize the need for vaccine coverage in both flu and COVID-19 through community pharmacies, and present the FIP guidelines on the topic. So it is my great pleasure to introduce Mitch Rutholz, and Mitch is an immunization consultant from the United States of America. Over to you, and you're very welcome.
Thank you, Dara, and thank you for having me with you today. I'm going to give a quick overview of the topic of pharmacy-based vaccine co-administration. I'll be sharing some data, but really the message across all those slides on the data is that COVID has impacted the vaccination rates for flu and other vaccines, and it's time for pharmacists and our other stakeholders in the immunization community to really start focusing on getting our immunization rates back to where they were pre-COVID. And it gives us an opportunity in pharmacy to play a major role in that activity. Next slide, please. This study that was done by Avalere, and I have two slides that show this, but basically in the early days of the COVID pandemic, where we didn't have vaccine yet, there was a big push for the public to do what they can now to protect themselves against vaccine preventable diseases. And so there was a strong message across the globe for individuals to get the vaccines that are available, especially those that are related to respiratory illnesses, so that they are protected, and at least we can check off or say, okay, it's not flu, or it's not RSV. Well, we don't have a vaccine for RSV, but it's not pneumococcal, or it's other respiratory illnesses. So that we saw a little, we saw an uptick in flu vaccination. But then once the COVID vaccine was made available all across the board and through the pandemic, we were seeing less administration of other vaccines because everybody was realistically focused on COVID vaccination. Next slide, please. And so we didn't just see it in adults, we saw it across the lifespan. Our childhood office visits dropped dramatically. Our adolescent vaccination rates dropped dramatically. Again, people weren't going out. People weren't going for medical visits. And that impacted the ability for individuals to get vaccinated. Pharmacies, they weren't going actually into pharmacies. We were using other mechanisms during the early days of the pandemic, where either it was curb pickup or it was delivery, or telehealth really came into play early in the pandemic. So again, people weren't visiting their healthcare providers. Therefore, if you're not seeing them, you can't vaccinate. So it showed that we were seeing less care. People were delaying routine care until they got a comfort level with what was going on in the pandemic. Next slide, please. And so in terms of those over 65, as we all know, that's a population that we really need to pay attention to because of their chronic illnesses, and really try to get routine care, chronic care back to where it was pre-COVID. And so we saw a significant decline in wellness visits. We saw reduced ambulatory care. We saw that reduced, we saw it in pharmacies where people were not coming into pharmacies personally. And again, as I said, telehealth was playing a role in here. And so where we saw before the COVID vaccine was available, the rates weren't as bad. Once COVID vaccine became available, all attention was given to the COVID vaccine. And then we had different messages that were coming out from different government agencies in regards to early on in the pandemic, co-administration. When the COVID vaccine came out, recommendation was not to co-administer, but as studies and experiences became more norm, the answer changed, where it was encouragement to give co-administration of other vaccines. So that, again, once something got set in the healthcare provider's mind, we had to untrain it out of their mind and just strengthen that recommendation that it's okay to co-administer vaccines with the COVID vaccine. Next slide. Pharmacy has filled the gap. I don't have to tell this audience, globally, pharmacy has stepped up and shown its value to the healthcare system. It's a shame that we have to make our case, but we've actually done it by action. We've actually shown that pharmacies are accessible healthcare providers who can improve public health. And these slides here, this slide and a couple of ones I'll show after this, really show where we saw that change that COVID had on other vaccination rates. And I'll focus on flu, but this really also applies to all vaccines where we saw a decreased rate. Next slide, please. This slide here was an analysis that the U.S. Centers for Disease Control has been following where people are getting vaccinated. And what this graph really shows is the difference. As we talked about earlier, people were not going to their medical offices like they were pre-pandemic. But pharmacy was an accessible healthcare provider. And not only accessible, it was accessible at times when patients were comfortable going in. Because of our extended hours, our reach within communities. Those are values that really play out to why pharmacy is a major player in these public health situations. Next slide, please. So you see here this analysis that looked at child and adolescent, and the same thing applies for adults. But pharmacy has become, for immunizations, at least during the pandemic, the major source in the US and in a lot of other countries, major source for vaccine administration, which is good. I mean, because again, that repositions us as healthcare providers of not just medications, but of healthcare services. Next slide, please. This slide here, COVID, we've shown by the numbers what impact we could have, where just in the US, as an example alone, pharmacies have been responsible for delivering and administering over 258 million COVID vaccinations. But as we were doing an analysis, we've shown that pharmacies have also administered more than 50 million influenza and other vaccines per year. So that access point is critical for our nations to be able to address the current public health crisis, as well as other public health situations. And so this is serving as an example that we could use in our advocacy work. Next slide, please. This slide again just shows again there where we've had certain populations and over the period of time of the pandemic where we've had ups and downs in terms of the public getting vaccinated. So again, before the COVID vaccine came about, we saw, influenza vaccine was a good solution for people who wanted to do something to protect themselves. The message was, get yourself up to date on your vaccinations so that you're protected against any of the other vaccine preventable diseases that are out there. And once COVID vaccine showed up on the scene, then people were focused on getting that. Next slide, please. Worldwide, there's opportunities, and we're now globally focused on trying to address those gaps in vaccination services, immunization, influenza rates, as well as other vaccination rates. In the box that's on the screen, the NHS actually put out a communication to providers, again, encouraging them to co-administer vaccines and talking about the potential of circulation of influenza this coming season. As we've taken away a lot of the restrictions, people are coming back together, congregating. There's going to be an opportunity and a chance for spread of respiratory illnesses. And so we want to have people protected where we've got a vaccine that can protect them, like the influenza vaccine. Next slide, please. So the concept that we've built on in the US and globally has been what we call the immunization neighborhood, and has really played out during COVID to show how pharmacy and other healthcare providers can come together to serve the needs of a community. And really it's collaboration, coordination, and communication among stakeholders to protect our patients as well as our communities from vaccine preventable diseases. Critical to that is collaboration among the healthcare providers, focusing on the needs of the patient and the community, and then assessing, administering, and referring. So even if you don't currently administer vaccines, you have a role to play if you are specifically serving certain patient populations. Next slide, please. I put this slide in here to acknowledge that our pharmacists, our profession, and healthcare is stressed and stretched given the COVID pandemic, as well as other healthcare needs in our communities. And this just gives a depiction of what pharmacists have been doing during COVID, all the different services that we've stepped up to provide to our communities that, again, have placed a stress on our healthcare system and on our providers. And so the question is, as we're now asking them to reinstitute co-administration of vaccines, how do we approach that without burning out our members? And so the next slide, please. When we're trying to reinstitute other vaccines besides COVID, individuals need to look at what they can handle in their practice. And at a minimum, everybody starts out when they do immunizations with influenza. And so if you're moving from COVID to now co-administration of vaccines, influenza is the logical step if you're not going to institute all of the recommended vaccines, and you need to do it in piecemeal. Start with flu and then grow from there. Again, during this fall is going to be opportunity for us to address respiratory illnesses, vaccines that prevent respiratory illnesses, and flu is top on that list. So what I've been encouraging folks is, because of the stress that I just talked about previously, look at what your practice can handle and institute what you can logistically administer in your practices. It may be COVID and flu, maybe offering them all, depending upon what support systems you have in place. But we do need to stress to the public the importance of being up to date on their recommended vaccines. Next slide, please. In the pharmacy patient care process, there is in that process, we have built in immunizations in our model here in the US, and encouraging all providers to assess the patient's immunization status, identify what their needs are, and either, of course, make a recommendation of what vaccines they need. And again, it's ultimately the patient's choice on what to get in terms of vaccines, but then either administer it or refer them to somebody who will administer it to them, and then make sure it gets documented in a system. Next slide, please. So again, this slide here just reiterates what I just said in terms of a role that everybody, whether it's pharmacists, pharmacy team members, or medical or nursing or other providers in the system, everyone has a role to play in immunizations. Next slide, please. When you're instituting routine vaccines, again, we talked about that your older patients with underlying conditions are individuals who we should target for this messaging. And that ask yourself the question in terms of what's the right time to focus on routine adult vaccines. And in the area where I'm in, we're entering our flu season. So again, while we're giving COVID, we're getting ready to do the bivalent vaccine. We're also going to be giving the messages pretty strongly about influenza vaccine. If you're going to co-administer vaccines, whether it be with flu or other vaccines, recommendation is that you administer them in separate arms so that you can monitor any kind of reactions. We've got history of co-administration. Next slide, please. In terms of it not being a problem, okay, they may have a more sore arm, but it's not going to be something that will harm them. So again, the key to this is informing the patient what to expect, being open, listening, and then if they're ready to be vaccinated, provide the vaccination, whether it be just COVID or COVID and flu vaccine or COVID and flu and other vaccines. There are recommendations in place for giving 2 vaccines or more in place. But again, having that discussion with the patient, looking where they have their gaps, and coming up with them a plan on how to fill those gaps. Next slide, please. In this recent survey that was presented at our ACIP, which is our advisory committee in the US, 63% of respondents are ready to get their flu vaccine along with their COVID vaccine during the fall. That's a good sign. Hopefully that will play out in action by the public, but the public is even ready. They understand the importance of protection because they don't want to go back into a situation where we have to be restricted in our activities. Next slide, please. Parents are also ready, but weary in some ways. They're what I call vaccine. They're contemplators, where they're not anti-vaccine. They just want to have the information and have a comfort level with what we're doing for themselves and more for their kids, whether it be the younger children or the adolescents. They still have questions in terms of co-administration. And it's our role as healthcare providers, along with our other members, our immunization neighborhood, to give consistent messages about it's okay to get co-administered vaccines. Next slide. And we see patients in our practices every day who need vaccination. And so we play a critical role of message delivery as well as access to administration. And so I encourage the audience to consider where in your practice you can incorporate having that discussion about immunizations, and how do you go about actually being able to administer vaccines yourself. Next slide, please. There's an opportunity also through WHO, through their campaign. As you can see, I put here just to give this for you to start thinking about. There are many parts in this plan where pharmacists can play a role to help address progress towards their vision. And so look at this document as well to see where in your country where pharmacy can play a role. Next slide. So this is my last slide. Again, I encourage everybody, do your part in this activity. We have proven that pharmacy can make a difference, and that by our action, we don't have to prove ourselves. We're proving it through our action. And so thank you for having me on this, and I look forward to the panel discussion.
Mitchell, thank you very much on behalf of the other panelists, myself, and everybody who's watching. That was a fantastic presentation. I meant to do the introductions at the start rather than at the finish, so my apologies because I didn't introduce you very well. Mitchell is a pharmacist who retired on the 1st of July from full-time employment after 28 years from the American Pharmacists Association. He is an organization management and immunization consultant, and he also currently serves as the secretary for the Joint Commission of Pharmacy Practitioners. Mitch is recognized globally as being an expert on pharmacy-based immunization delivery, and he has supported dozens of international pharmaceutical federation immunization initiatives. During COVID, he is an active member of numerous task forces and work groups. So again, Mitchell Rotholz, thank you very much for his fantastic presentation. So ladies and gentlemen, our next contribution comes from Ruben Viegas, and I'll just bring up his introduction. And it's from Ruben Viegas, and he's the FIP Practice Development and Transformation Projects Coordinator, and he comes from Portugal. He is a pharmacist with a master's degree in exercise and health from the Faculty of Human Kinetics in Lisbon, and he's currently enrolled in a PhD program focusing on the promotion of physical activity through pharmacists. He has been involved in different association and educational activities focusing on the area of public health and pharmacy practice. This is a recording, so let's let it roll.
Good morning, good afternoon, and good evening, everyone. My name is Ruben Viegas, and I'm the FIP Practice Development and Transformation Projects Coordinator. I will present the publication we're launching today entitled Optimizing Vaccination Through Co-Administration of Influenza and COVID-19 Vaccines, Guidance for Pharmacists. As discussed during this event, co-administration of COVID-19 and influenza vaccines can provide a critical opportunity to increase protection of patients and the community of the dual impact of the respiratory illnesses caused by these viruses. This publication explores how vaccination strategies for two important respiratory conditions, COVID-19 and influenza, can and should be considered together and combined in a synergistic manner to improve uptake rate for both vaccines. Both diseases spread in similar ways and can have a big impact in the quality of life and functional ability of individuals. Likewise, both have vaccines that support a lower risk of transmission of the disease and minimize their clinical severity. Vaccination against the seasonal influenza and COVID-19 is one of the most important strategies to reduce the transmission and severity of the diseases. However, administration of influenza vaccines has generally failed to meet the rates recommended by the World Health Organization and other organizations over the years. This represents a challenge for the health systems and is critical to learn from the past to avoid repeating the same mistakes when it comes to designing long-term strategies for COVID-19. Vaccination against COVID-19 was one of the main contributors to the decrease of disease transmission during this pandemic. Having access to the vaccine is therefore an important step to prevent disease and alleviate the pressure on health systems. The recent FIP publication, as you see on the screen, advocating expansion of the pharmacist's role in immunization, a focus on diphtheria, tetanus, pertussis booster, COVID-19, and meningitis vaccination, informs, as you can see on the table, on the countries where pharmacists play different roles related to COVID-19 vaccination and which roles are available in which countries. When it comes to influenza, the influenza vaccine is one of the most common vaccines that are allowed to be dispensed and administered in community pharmacies around the world. For that reason, it is important for pharmacists to understand the different vaccines that are available and how to provide information about these vaccines to their populations. Pharmacy-based interventions are successful to support the uptake of influenza vaccines. An overview of interventions highlighted that vaccination programs for influenza yielded a 27% increase in vaccination acceptance compared to standard care. COVID-19 and influenza share some common features and characteristics, as both affect the respiratory system and have similar transmission patterns. Respiratory viruses are transmitted via different routes, including direct and indirect contact, droplets, and airborne transmission. Despite these similarities, there are some characteristics that pharmacists can use for advising on the best treatment options, if available in the community pharmacy, or the best referral pathways to other healthcare professionals. Previously, WHO recommended a 14-day interval between COVID-19 and any other vaccine. However, with further research, many countries and the WHO itself are encouraging co-administration to optimize protection from vaccine-preventable diseases, maintain vaccination rates, decrease hospital and medical visits, and to improve health services by the concurrent implementation of both vaccines. The COVID-19 vaccine should be co-administered with the influenza vaccine without regard to timing. However, the WHO also recommends the contralateral limb, so it should be administered on another arm or another injection site, at least 2.5 centimeters apart. The importance of the co-administration of the influenza and COVID-19 vaccines is linked to the fact that the influenza season will coincide with the ongoing circulation of the SARS-CoV-2 virus. If having a conversation about one of the vaccines, there is an opportunity to engage in a conversation about the other one. Pharmacists can also highlight the importance of vaccination to high-risk groups, are those as frequently visited community pharmacies, in order to access medicines and services. Each time a person walks into a pharmacy is an opportunity to engage in conversations about vaccination. Pharmacies can serve as powerful reminders for vaccine uptake and as important allies in solving questions related to vaccine hesitancy, as highlighted in the FIP Building Vaccine Confidence and Communicating Vaccine Value publication that you see on your screen. To ensure the pharmacist can be part of vaccine administration, the points presented on this slide need to be considered from a policy and regulatory perspective. These are highest level advocacy, policy dialogue, partner engagement, and resource mobilization, evidence-informed and ethical values-based national vaccination strategy, legal and regulatory framework facilitating vaccine deployment, immunization service delivery modalities, vaccine and supply chain management, human resources and security, vaccination data and information management, vaccine safety monitoring, injection safety and waste management, demand generation, community engagement, and communication. These building blocks are important pieces that the national pharmacy associations may strive to include in their pharmacy-based vaccination plans in order to showcase the pharmacist's value to stakeholders and political decision makers. If you have any questions about the publication or any other work about FIP, you can consult the FIP microsite on vaccination at prevention.fip.org/vaccination or contact me at ruben@fip.org. Thank you very much for your attention.
That was a great presentation, and on your behalf, I thank Ruben and the team at FIP for putting that together. Our next part is to talk about the panel discussion, and I'm delighted to say that we're on time and we have lots of time for a great panel discussion, which is great because we have great contributors and I know that there will be lots of questions. So just on a housekeeping issue, we'll have already seen it flag up that to get the questions and answers going, if we can use the Q&A box rather than the chat box, and we'll do our very best to integrate everybody's questions. And we're just going to try and roll with it as well, because there's different areas of expertise that we have from our contributors who are the panelists. And I think we're going to have a great chat and a great opportunity to discuss how things work in different areas of the world and how we can get people access to the best services through their community pharmacists, particularly looking at vaccination. So with that in mind, I also want to say that we will have all of the detail here ready for you on the FIP website, which will be findable and trackable, downable, and all the rest of it, because that is some of the questions that I see coming through. So that will all be available and we will be sharing those links, but it's all very findable on the FIP website too. So if I can move on now, I am going to, with great pleasure, introduce our three panelists, and in alphabetical order by their surnames, as I've noticed is put together, which I think is very fair. I'm going to start off by introducing Shyam Mughli. Shyam is a community pharmacist and he's based in Durban, in the Durban South Basin area in South Africa. His academic background includes a Bachelor's of Science in Pharmacology from the University College in Dublin. He has a Bachelor's of Pharmacy and a postgraduate diploma in HIV/AIDS from the Stellenbosch University in South Africa, and a Master's cum laude also in a university and a PhD from UKZN. He was recognized as the South African Pharmacy Council's Pharmacist of the Year in 2008 and Community Pharmacist of the Year in 2019. He has served as elected member to the South African Pharmacy Council from 2013 to 18 and chair of the disciplinary committee, current joint chair of the Pharmacy Stakeholders Forum, Pricing Regulation, and he's the vice chairperson, a member of the board of directors of the ICPA, chair of the NHI Pharmacy Stakeholders Consultative Forum task, and I think really, really pertinent to today, that he has been the Forum Pharmacy lead in the COVID vaccine task team for the B4SA FIP CPS. Shyam regards himself as a dedicated healthcare professional with a passion for patient care and believes that pharmacy has a major role to play. He is involved in many projects and focused on clinical outcomes at practice level. Our next contributor is Dr. Lisa Nissen, and she is the head professor and head of the School of Clinical Sciences at Queensland University of Technology. She is an experienced pharmacy practitioner and a researcher and educator, having worked in hospital and community pharmacy in metropolitan and rural areas of Australia. Her focus is on improving the quality use of medicines in the wider community, with the focus on a health service development and factors that influence the prescribing of medicines. In 2021, she was seconded to the Queensland Health COVID-19 Vaccination Task Force as a senior expert advisor on the vaccination rollout across the state. Lisa has been a key driver and expert in the profession nationally and internationally for scope of expansion for pharmacists in vaccination. So a big welcome also to Lisa. Our final contributor for the panel discussion is Paula Teixeira. Paula is a scientific information manager at the Centre for Medicines Information and Health Interventions in the Portuguese National Association of Pharmacies, and she's been in that role since 2015. She has a specialty with immunization and diabetes are the main areas of her expertise. She qualified as a pharmacist in 1999 and has experience in both community and hospital pharmacy in that time. She's particularly interested in public health interventions in the community pharmacy, and that's been her main area of interest and work, as well as the support to specialised inquiry services that the ANF, the Portuguese Federation of Pharmacists, provides mainly to community pharmacies, but also to hospital pharmacies, students, and other ANF departments. So those are our three contributors. So again, I'd ask you to have a look at that. So what I'm going to do is I'm going to start off with a question which I would like maybe Lisa to get the ball rolling with, which is to say that vaccine co-administration is a relatively new service in community pharmacy. What do you think are the main enablers for pharmacy-based vaccination that ultimately leads to vaccine co-administration? So Lisa, if you wouldn't mind giving us your experience from helping to roll that out in Australia, and then we'll be able to get the ball rolling with the other contributors. So again, that is what ultimately leads to vaccine co-administration in community pharmacy. Over to you.
Yeah, no, thank you. And thanks for the opportunity today to join you all. Look, I think we had the benefit of having a flu season that coincided very much with our COVID season. And I think we struggled initially very much with the guideline messaging that was coming out internationally and then from our national medical organisations around some of the, I guess, advice around co-administration of vaccines. So I think if you look at barriers and facilitators, I think some of them, the way that the media messaging and some of the messaging that comes out from various organisations can confuse some of our patients and consumers and even our own professions around what is the advice or not the advice. I think when pharmacists are very busy in their pharmacies, particularly if that's the site of vaccination for many people coming in for flu vaccines and COVID vaccines, they may not always be able to be at the front line of the changes around the guidance. And we found that in COVID, particularly, that the advice and who was eligible and what they could have and which vaccines were for different ages and what the contraindications were, etc., changed rapidly at a national level and a state level. And it was hard for people on the ground to be keeping up with what the various guidances were. So I think information and what is the most current information and what people can do. And I think Mitch touched on that the initial advice was you can't do these things, you can't put them together at the same time, you have to put a 2-week gap. And I think that's one barrier that we can overcome is by keeping people up to date through our professional organisations and through other news feeds around what people can do. What needs to be done, I think, is in overcoming it is opportunistic conversations and using the things that we use in pharmacy all the time, which is using our ancillary staff in pharmacy, our technicians and assistants and other staff that are in pharmacy to flag people around, are you up to date with your vaccinations? Have you thought about having a flu vaccination? Have you had your COVID vaccines? And starting those conversations and filtering them through to pharmacists and pharmacy staff to have conversations about their vaccines so that you can start that conversation about having not only a flu vax, but all other vaccinations that they might be eligible for at that point in time. So I think it's making sure that everybody else in the pharmacy is part of the vaccination neighbourhood and vaccination family, like Mitch talked about as well.
Yeah, that's a super answer, Lee. One of the things, there's a couple of things jumping out at me from your experience then. So one of the things that you said that there was mixed messaging and trying to get everybody pointing in the one direction. That's going to be particularly hard to do with something as new as COVID-19 when it came to us all out of a shock and what I might do now is maybe ask Sham to lead on from that, because Sham has great experience in doing things that are new with his work with pharmacists in South Africa when we were looking at HIV and AIDS, which has been around a lot longer. So maybe if you could pick that part up, Sham. And then the other thing that I really like that Lisa pointed as great advice would be to take opportunities using the entire team who work in the pharmacy. And because we are embedded in our communities as community pharmacists, to talk to us a little bit about how teamwork in South Africa helps with that opportunistic introductions. So if I could go over to Sham for those answers, please.
Thanks, Dara, and thank you very much for this invitation to be on this esteemed panel. So I think that the important concept is that, especially in a pandemic, and I think we've been through some epidemics and pandemics over the years, is the issue of getting everyone pointing in the right direction. And I think we've kind of managed to do that in South Africa through a business concept called Business for Africa, B4SA. And we got business leaders across the board, including those in the healthcare sector, to combine forces and provide the necessary resources to deliver this project. So we had experts on a panel, including scientists, etc., that managed to give clear guidance on what the way forward should be. It became then easier to implement at a community level. So for us then, the guiding documents, the guidelines, just through these last 2 years with the pandemic and with the COVID vaccines, and then the combination with the flu vaccines, for example, was clearly provided by both the business unit that had the experts, and that filtered very quickly into the pharmacy organizations. And I must say that within the framework of the 2 years, an organization like the Independent Pharmacy Association had written something like 32 documents to give guidelines inside the pharmacy. And one of the key issues inside the pharmacy then is to ensure that you utilize the resources of everyone in your environment. And that's a key differentiator. The pharmacists can never do everything on their own. So what we kind of done in our own pharmacy was to create the expert team led by a pharmacist together with the technicians that assisted. We employed an additional nurse and used the current nursing sister that we use. So we had 2 nurses. We had to have some administrative staff that we brought in, and we managed to actually do around 17,500 vaccines over a short period of time in a small community pharmacy. And I think that's exactly how we prepared and planned and administered this. The other big contributor, I think, would be to ensure that you have the regulator on your side. That's an important step forward. And we managed to do that quite nicely because remember the COVID vaccine is a higher schedule and you normally would need a prescription for that in South Africa. I'm not sure what the status is in the rest of the world, but the fact that you needed a prescription, it means that those patients could not get easy access. The Pharmacy Council in South Africa issued what is called a Section 22A15 permit that is signed by the Director General, allowing pharmacy to both prescribe the vaccine, although it was a scheduled product, and to administer it. So that Section 22A15 was issued to around 2,000 pharmacies in the country that then had the ability to vaccinate. Thanks, Dara.
That's really good information. So what I'm listening then from that, like it's fascinating to say, is that it is one of those things that we need to learn as pharmacists to get use of all the resources that we have within the community pharmacy, which is the people, isn't it? And then interestingly, the relationship that we build with our regulators is really important, because I suppose ultimately the regulator has to have the confidence that we can do what it is we say that we want to do. Some of the questions early on that I'm seeing coming through in the Q&A are kind of answered by that, because there's looking at specifics just as to say what the interval of dosing should be, what about the age groups, what, you know, I think that's where the importance of working hand in hand with the regulator comes from, because we will all be regulated differently. But in terms really that what we're being asked to do is to use best science at that very time to be able to get the right medicine to the right person at the right time. And pharmacists are really good at that. So rather than specifically answering those questions, which are really good questions that have come through on the Q&A, I think broadly an umbrella answer to that would be, just as Sham says, it's really important to work with the regulators and also to be able to give them confidence that we can do what it is we say that we can do. And the proof positive is out there through FIP, but also through our own national immunization services in countries where it's worked. The statistics are fantastic. Maybe on that line of the medicines information and being able to prove that things work, I might ask Paula to come in now. And one of the questions that seems to be out there is that we need to go and prove to regulators who we are and what we do. So maybe by using the information and your experience in Portugal, you might be able to talk to us and say how we use information to bring that forward to regulators and also to government. Because as Shan pointed out, we need to be also able to make the business case for it, which then goes beyond the regulator. So please share some experiences from Portugal with us, Paula.
Oh, hello. In Portugal, pharmacists are available to administer vaccines against COVID-19 in pharmacies, but the government has opted for vaccination at NHS vaccination centers. So co-administration of vaccines against COVID and influenza, it's only carried out within the scope of NHS. The pharmacist can't administer COVID-19 vaccines, only the flu vaccines. But I think the most important role from the pharmacist in Portugal is have information that it's up to date, to inform the people about the vaccines, counseling them to get the vaccine. In Portugal, we have a very high rates of COVID vaccination rates. So I think in that case, we are very, very well. But pharmacists effectively only can administer the flu vaccine. So in regarding to the COVID, they can only advise. We develop a lot of material to give to the people, to inform the pharmacist. I think that was the most important work we had to do, because we couldn't administer the vaccines with a lot of are very unfortunate for those, because we have already proven that we are capable, that we have technological and physical conditions to do that, but unfortunately we can't do the vaccination. This week we'll start the co-administration of flu and COVID vaccines for old people in Portugal, but the flu administration in pharmacy only start in the end of September. So we are continuing to advise people to get vaccinated, showing them that it's the best way to avoid the COVID in the flu. I think that's what we can get. But regarding to co-administration, since that we have the service, the vaccine administration service for 14 years in Portugal, we always have the co-administration, vaccine administration. The pharmacies. About 78% of the pharmacy in Portugal have the vaccine administration service. So we do not see the co-administration service as a new service. The people in the population are used to go to the pharmacy to get the flu vaccine, not COVID. They know that they can't get the vaccine in pharmacies.
Okay, that's an interesting experience then that we have from Portugal. Because I would imagine most people who are tuned in today would find it odd that you can administer one vaccine but not another, particularly through a pandemic. And I suppose I have to ask the $60 million question, Paula.
Why?
How did that happen? And my own little head scratch is it because the uptake rate through the NHS was so high that the regulator, was it the regulator? Was it the government?
They could.
These are the important questions. Yeah.
I think the vaccination plan for COVID-19 was well performed, and they can vaccinate most of the people that were indicated to the vaccine, especially the old people. So maybe for that, because regarding to the flu vaccine, the pharmacies can administrate with their own stock, but the pharmacies that have partnership with NHS could administrate also without a prescription and with no costs to a determined group of people that have certain medical conditions that they can prove that they have that conditions. Some pharmacies can administer from the stock of NHS too, but with COVID, unfortunate for us, that because we always get disponible to administer, but I think it wasn't necessary, unfortunately for us. I think,
Okay.
I hope in the future that the things may change.
Okay, well, we hope so too. So
Yes.
what I'd like to do is I have another question here, and maybe on the back of the fantastic presentation that Mitch did, I might maybe get him to get the ball rolling on this one. And the question is, in many countries around the world, there are still low involvement from pharmacists in vaccination-related roles. Which barriers for this involvement do you think are more important, and how could we solve at least some of them? So if you wouldn't mind getting the ball rolling on that, Mitch, please.
Sure. Thanks, Dara. Great question. Couple of points. Educating our teams is important for the comfort level. So whether it's the pharmacists, our student pharmacists, or pharmacy technicians, all need to be educated about vaccinations, about answering some of the questions that the public will raise, and having the confidence level, especially around co-administration, that it will not do harm for a patient. And how do you approach a patient who may be hesitant in answering their questions, listening to the patient's concerns and providing information. So I think education and having credible information, evidence-based information is important for our teams. But then, as was talked about earlier, authority by our decision makers, where pharmacists, pharmacy technicians have the authority to administer vaccines when the patient is ready to be vaccinated. One point I want to bring up was talked about earlier. I've always, we were doing this in the United States, is that we've been successful with, is we've raised the question of access. Is access, the challenge of access, especially in vulnerable communities, is that a public health crisis? And is that a crisis that pharmacy can address? Answer is yes. And given that, why have a patient go from one site to another to get up to date on their vaccines? And we're missing an opportunity. And so that's part of it. But then also behind it, that's critical to everything, is payment for sustainability of access, and having those community providers willing and able to give vaccines. You always have to have that payment mechanism in place to support the continuation of those services, and then to support across and also consistency in messaging across all health professions.
That's a super answer, Mitch. And it probably goes to show why this is such a fascinating conversation to have as pharmacists, is there's a lot of moving parts involved. So if I might now just bring Sham in, because Sham also mentioned about the ability to make a business case and to apply resources to it. Two things that I'm taking is very striking from your answer there is that we need to be able to build confidence within our teams. We need to be able to educate ourselves as pharmacists, and this is new for so many of us. I remember doing my first flu vaccination and being absolutely terrified, and I'm glad to say 10 years later, I'm a lot better at it. I still have a little bit of terror, which I think is a good thing to have when you're about to vaccinate somebody, because it's an important role that you're fulfilling. But I'm just thinking from my own practice and pulling out those two important things that you say about being able to educate your team. You need to allocate a resource to that, don't you? You need to be able to say to yourself, if I undertake this service, I have to dedicate a space like I have here now. I have to dedicate my time, and I have to dedicate the team to looking at that and everything else that happens. So Sham, maybe if you could bring that on with us, is to see how that experience worked in South Africa about the balancing act between resources and then also the allocation of the time and how that works in, because teamwork is coming through so much in the answers that people are giving.
Yeah, that's a really interesting question, Dara. And I think over the years, I suspect that we struggled at pharmacy in trying to peg our services and try and put numbers to it. And I think across the world, and I'm sure in FIP, there was a document I think we did last year, at the beginning of last year sometime, in trying to facilitate payment around pharmacy services. So, and this is one of those services that we would probably have an ongoing debate about. So I think you need to just separate it in terms of administering in a pandemic like we did. And I think a lot of that, what we did in that pandemic was almost volunteered our time to try and solve a crisis. And I think that's where pharmacy took a real cut in terms of what the payment was. So we did it at a cost, a bone dry cost, and no meat added on that. And we administered for the year. But we've recently put in a document and reapplied for an increase in that funding. And I saw some documentation last year in the US where the number was pegged for the vaccine services, and then the associations applied for an extension of that and did a good motivation on why they think they should get better paid for that service. So I think that's the one important thing, in that going forward, our services that we do outside of dispensing needs to be properly costed out. And I think many countries are struggling with that. So I think that's the first point I'd like to make. So in terms of allocating resources, I do think that as we move away from the reliance on dispensing, like they did in the UK, for example, where I believe more than 50% of their income comes from services, we're going to have to train more and more people to assist us with those kinds of functions in the pharmacy, so that the pharmacist can actually play that management role and define exactly what is important in terms of the pharmacy task from a clinical point of view. We sometimes get caught in the process of dispensing, for example, in capturing the data. Should we have the technicians do that kind of work, and you do the endpoint analysis and guiding the patient on their drug interactions and their future disease plan, for example. And maybe that's where some of our work needs to be focused. So in terms of the overall picture then, the movement is towards redefining pharmacy services, costing them out properly, training staff to fit into those various services, and getting the pharmacist role more clearly defined, and using the team to support the pharmacist in that.
Yeah, that's a great answer. And I suppose what I want to do now is maybe get some feedback from the experience in Australia from Lisa, because as it's just flashed up from one of our contributors in the Q&A box, pharmacists were at the front line. Like, we really were a physical, face-to-face interaction with people when lots of other doors that they expected to be open to them were open to them. So I suppose I'd throw this one out and just say, did we do too much? Were we too nice? Were we saying, like, we had them over a barrel? Maybe we should have charged them more for all the time that we don't get paid for all the pro bono stuff that we do. So yeah, I'm going to fire that one at you. We were suckers. We did it all for free and went back to look for money after. What's the answer from Australia? We're suckers.
Lucky I was on mute when I said that. I was reflecting on Paula's experience and not being put into the mix of giving vaccinations. When she was speaking, because as you said, all our doctors' surgeries shut as soon as sort of COVID came. The shutters went down, and they said, you go to your pharmacy and get your blood pressure tested, and they'll monitor your BGLs, and don't come here. We don't want to see you. And pharmacy was open. Pharmacy was the primary care service that was available. And the double-edged sword really in that was, we were open and we were available, but they got slammed. But they stood up. They did a really great job. And as you said, did we put ourselves to the sword because we did that? But it became a policy window for the profession. because we were available, we got really first pick when the vaccinations started to come out of our acute care vaccination clinics, particularly because we had one of our first vaccines was the Pfizer vaccine. So the ultra low temperature, -80 freezers in our acute hospitals. They were saying, well, primary care can't really do that. Pharmacy said, we can do cold chain. So if you can deliver us a vaccine that's defrosted, we can manage a cold chain. And so we actually, through being available, through being open, where GP said, we can't do that unless you get us a $30,000 freezer, we're not doing vaccination. Pharmacy said we can. That immediately opened a door for us. Now, the corollary is that we got $16 a vaccination, and I'm not talking out of school, and GPs got $130 to do exactly the same thing. So we did get put to the sword, but that was the first time that the government had paid pharmacists at a Commonwealth level to give vaccinations. So what it set up was a payment system. It set up a national system for pharmacists to be paid for a service by the Commonwealth government. And it opened up a network now for professional services to be remunerated nationally and vaccination services to be remunerated nationally. That would never have happened. And now flu will be able to happen through that and all other vaccinations. Now, what the profession doesn't do to help itself is that influenza vaccines, which we've had now for coming up to a decade, close to a decade in Australia, when we first did the pilots for that, we had a professional services fee on top of the cost of the vaccination that was around, $25 for the service of counselling and seeing whether somebody was eligible, giving the vaccine, and then the cost of the vaccination. Some of our larger chain pharmacies came in and offered them for $7 total. So they completely undercut the professional service and made it a loss leader and undercut the value of the professional in the professional service. And so we do it to ourselves. We devalue the pharmacist in a professional service. So I think that's, something that we need to think about when we are having these conversations, Sham, at an international level as well, is valuing ourselves. Because I think we give a lot away for free all the time. And we often say, well, people don't want to pay for what we do because we give it away for free. But when we have a chance to actually value ourselves, we then cut the legs out of it. And we make ourselves the cheapest we can possibly make ourselves. So I think that's a lesson. But I think one of the big points was there was a massive policy window that opened for pharmacists to come in and say, we can deliver vaccinations. And as of this week, pharmacists in Australia are delivering more vaccinations than all other providers combined for COVID. And are edging up as the largest provider of influenza vaccinations in Australia at the moment. So the government love us right now, and now that's opening up great discussions around being fully funded for all of the National Immunisation Program vaccines through the new portal that's been opened. So there was a pain, but I think there'll be a gain down the track.
Okay, I like that sum up. So there was pain, but there is gain as well. Yeah, I think that's how, yeah. Again, Paula, going back to talk about, health information, which is your area of expertise in that, and also marrying that then to say, are you confident that you can go to the National Health Service in Portugal and compile data and say, this is what we can achieve with this set of resources, this is how much it costs to do. Does that make sense? Are you putting together a case like that maybe other countries could learn from people who are listening in today?
Yes, in Portugal, we don't have the COVID vaccine, but regarding, for example, to flu vaccines, we can administrate from NHS stock, and we are paid for that. Not very much, but the pharmacies that administrate from the NHS stock, they are paid. But regarding to the values and what we need to prove to others, I think it's very difficult to deal with that. It's not in my expertise, the dealings with that, only the board. But we try. And we have shown that we have the capability to do that. But that kind of negotiation, it's not very easy. Maybe if you had the COVID vaccination in pharmacies with the pandemic and in the whole of that matters for the country, and maybe we could deal that thing. We have the flu vaccine for a lot of years in Portugal, and we are trying every year to can achieve a little bit more, but it's not easy. It's not easy, an easier task to deal in Portugal.
Yeah, look, and let's face it, as we discussed this really important topic as FIP, I can be corrected if I'm wrong, I understand there are only 16 jurisdictions around the world where pharmacists are vaccinating against COVID anyway. So it's, you know, the discussion is always going to focus on the minority of countries that are out there that are actually doing it. Look, that's what FIP exists for. We are here to be able to share best practice and to share the learnings as to what the barriers are and what the enablers are. I suppose then to go back and look at that, if I can tap into Mitch's expertise here, we have another question here, which is pharmacy-based co-administration might start with routine administration of flu vaccines on a yearly basis or COVID vaccines during the recent pandemic. In your experience, how well was the vaccination service for any or both of these conditions perceived by the community? Because one thing that I'd like to say is I really like it when these conversations that we have as pharmacists aren't about pharmacists per se, but they're about the people that we serve. So Mitch, if you would get this get the ball rolling, because your expertise can tell us, what do people think? The people that we serve, what do they think? What do they want from a vaccination service?
So great question, Darren. I think the key to a lot of the public is access, and access that is easy for them, where they don't have to take off from work to get vaccine or extended hours, play to our benefit. Where other healthcare, I think Lisa said this, where other healthcare providers were shutting down, and specifically during holiday times, pharmacies were open, and pharmacies had late hours. So I didn't have to take my child out of school. I didn't have to leave work to get vaccinated. That was a value added that the public has recognized. And so having the trust, pharmacists are trusted healthcare providers in communities and respected. And we need to play off of that, because that relationship, especially during COVID, really showed itself how valuable that is. And the point I want to bring to the audience is the process of vaccination, whether it's done by a physician who usually don't do the vaccines through their staff, a nurse or pharmacist, it's the same. So the payment should be equitable across all the healthcare providers. It's the process you're paying. What we don't have in pharmacy is we don't have the ability to bill for an office visit. And so we're dependent upon what reimbursement we get for that vaccine service. So that's one of the things, but we're facing that now in the US as they're trying to move back from COVID, paying extra for COVID vaccinations, to what it was pre-COVID for vaccination. And we're saying we've got a new norm. We've got a new process that providers would have to go through, and that comfort level that we give the patients on our ability to administer, the processes we use, and how educated we are on immunizations all play out for giving that comfort level to the public.
Paula, I'd ask the same question to you then, because I know that there's a very strong relationship between community pharmacists and the promotion that ANF does to actually let people know what is available to them through their community pharmacy in Portugal. So on a more broader level, would you give us your experience from Portugal about different services that you run that build confidence in community pharmacy? Because I know you do really interesting stuff that we don't. Yeah, please tell us about the other services available in Portugal.
We have not only the vaccine, but the injectable drugs too. It's the same service. We have the individualized preparation of medicines. We have all the regarding to the measurement of the glycemia, blood pressure, the lipidic profile. We have a lot of other services, the medicines that are manipulated medicines too. So yeah, we have a lot of services in the population, the Portuguese population, regarding to the vaccine administration. They are already used because we have the service since 2008. Regarding to flu, for example, the pharmacies administer 40% of the flu vaccines. So the citizens, the population knows the service. We made the pharmacies made publicity of the service that provide. Not only all pharmacies have the old services. They can only have what they can to perform, but the population is used to go to the pharmacy in the first place to get something, some advice, some service. Normally go to the pharmacy because we have a very large number of services that we provide in pharmacies. You are trying to do new services and to implement new services, and I think the population are used in they used to go to pharmacy to that.
Okay. Does it? Yeah, and it must make for an interesting job then in Portugal also, if this many, these many services are available through community pharmacy, because we all like a little bit of variety in what we do. Sham, your experience in South Africa is interesting to me because I know from conversations with pharmacists and your national organizations, you are now trying to work with, because Paula talks about the NHS and also listening to Lisa's experience of dealing with regulator and government in Australia. You're really at an interesting phase because you now have the opportunity to say this is where pharmacy exists within a national health service in South Africa. So what are the messages coming from community pharmacists in South Africa, but also at a national level to say, this is who we want to be, these are the services we want to offer, and what difference has COVID-19 made to that as you go and advocate for people's access to services in community pharmacy?
Yeah, that's an interesting concept that we put on the table a while back when we are moving towards a national health insurance scheme, very much like the NHS, and that's what it's called, the NHI. And this has been going to Parliament for a while now. So we did do submissions on what we think the services that a pharmacy can perform. And we didn't have much traction on that over the last couple of years. But I think this pandemic has escalated pharmacy into the next level. I'll just give you a few examples of that. So the first is that during that first year, before the vaccines came in, as many of the speakers indicated, the pharmacies were the first port of call in the country. The GPs were closed, hospitals were closed to primary care. So a lot of the primary healthcare work shifted to pharmacy. And we now have data to show that, which we've been putting together and presenting at various forums over the last 2 years. Then the vaccine campaign came up. And the first to jump at it were the pharmacists. And yes, we undersold ourselves. I do think that. But the GPs actually stayed out of it for some strange reason. Maybe they were still scared of the pandemic. We have a whole older generation GP in the country, and maybe that's the issue. But I think currently, the only people in the private sector that's administering COVID vaccines are pharmacists. And the only team that meets 3 times a week at the moment at a national level with the Department of Health are pharmacists. And actually, the project is led by pharmacists. So suddenly, the Department of Health, together with the Director General, is seeing the pharmacists as their new best friend, because if they have any intention of delivering a comprehensive national health insurance program, somebody has to do the work. And they suddenly discovered this new friend called the pharmacist. So I think we're in a really good place. What we've been motivating within the structures of our organizations is to set up task teams and start to facilitate documentation to close those gaps. One of the things that was raised by Mitch, I think, was the issue of hesitancy and access. So I think that's another huge gap, because if you think about South Africa, we performed really well, reasonably well for an African country as compared to the rest of Africa. And we still only managed to get about 32% of our population fully vaccinated. So there's about 48% that took their first vaccine. So you can see we're well behind the mark. Now we're trying to investigate what are those reasons. So access is one of the things. And I think community pharmacy is really well placed in different communities. So trying to open that access door and make pharmacists the first port of call going into NHI would be probably where our strengths are going to be running in the future.
Okay, and when I hear you say that, is like, and then we hear the experience that Paula has in Portugal, would you like to see pharmacists testing for HbA1cs, for glycemia, for hyperlipidemia? Is that something that pharmacists want to do in South Africa? Is it the opportunity to put the case forward as you progress into national health insurance? Are pharmacists ready to do that with their teams in South Africa?
No, absolutely. That's already happening. And in fact, over the last year and a half, and I think this is really related to what we've done and what we've been able to show the country that we can do. A lot of the funders, there's a whole sector of private funding outside of government funding. Private funders have a basket of products that they will pay for related to pharmacy services, including the HbA1c, including counseling patients, including someone doing an asthma assessment on a patient. The schemes are now bundling packages and looking at paying for that service. I must say we haven't performed exceptionally well in that environment, and we're starting to build the products now to show the schemes that we can, because they've put in a few million rands into the basket. But if you look at utilization of those services and our pharmacists administered that, we've missed the opportunity over the last year. And I think a lot of that could be related to the fact that we're in the midst of COVID and a pandemic, and we are not able to perform other services. And it has shown worldwide that a lot of the other services have been put on the back burner. So that basket has opened up, and we're doing a lot of work in that area.
Brilliant. That's really interesting. Lisa, you have good experience in Australia too, and I see certainly like pharmacists' involvement in medicines reconciliation is really strong, and I know that you've gone out and done a really good job of showing the value that pharmacists are providing. But let's be frank, you're getting a bit of blowback as well, aren't you? There's a group in Australia who probably don't want you doing this. And in a way, I'm wondering if we took all the FIP logos out and we just then had the 30-second clip from here, people might think that they were listening to general practitioners talking about looking after patients, vaccinating them, doing their hyperglycemia. And I know certainly that, you know, it was just already in the International Pharmacy Journal experience of Canadian pharmacists moving people onto more appropriate inhalers for you know, getting them onto longer acting rather than short acting beta agonists. And that COVID, I'm being a little bit obtuse here, but I want you to talk a little bit about the bushfires, because this is where a lot of experience comes from. You need a crisis to make stuff happen. talk to us a little bit about respiratory medicines and the bushfires in Australia and what that meant for opportunities for community pharmacists to be better able to serve, because the experience of doors being closed to patients in Australia in COVID was not a new experience. So maybe you might just share their experiences from Australia with the people tuned in.
Yeah, no, thank you. And I think COVID was like almost the last straw. It did feel like the apocalypse in Australia because we'd had the floods, the fires, and then the pandemic was like the grasshoppers coming, really, because we'd had a very serious number of bushfires across the country that had meant, and I guess even internationally, people would have seen, not unlike the Californian wildfires, they'd swept very much through most of the east coast of Australia, and there'd been a number of deaths and many towns wiped out. And what had happened with that is that pharmacies and pharmacists again had been left as sometimes the only people providing a health service in a town and continuity of service for people where they'd literally run out of their house without any of their medicines or any way to support their medical care or even basic hygiene needs. So they turned up to the pharmacy, I've got nothing, and pharmacists were just giving them anything that they could out of their pharmacies to help support their healthcare, including jumping in, we call them tinnies, but small boats to travel between towns to try and get supplies and maintain health services. And to do so, they were breaking the law. Because most of our legislation didn't support the services that they were providing around continuity of medicines care, because we can't prescribe in Australia in that way in many of the jurisdictions. So pharmacists just did what they thought was the right thing to do at the right time for people in the bushfires. And had previously in North Queensland, where we get a lot of, I guess, the equivalent of hurricanes or tornadoes, we get cyclones. It's basically the same thing, where we'd had fairly apocalyptic cyclone events end on end over a couple of seasons. Pharmacists have done the same thing. They basically provided continuity of healthcare, acute care and continued chronic care for medicines and diseases for people. So by the time it came to the pandemic, where everything else shut, we just said, well, why can't we manage chronic conditions for people when the GPs have shut? So why can't we continue to give people their antihypertensives with a review or manage their other chronic airway conditions or their contraceptives or other medicines? Now, the flip side is that our medical colleagues are now trying to pull all of that back post-pandemic and say, well, that's because we were happy to accept poorer quality care while there was a disaster, and now that the doctors are back, we can have, exemplary care back, and we don't need you anymore. But the patients are voting with their feet. Similarly, we've just been running a urinary tract infection prescribing pilot in Queensland that's got a lot of press. Not good press from my medical friends, but it's about access, right? So people who have a urinary tract infection, women who have urinary tract infections want to get treatment as quick as possible. And if you can't get a doctor's appointment for 3 weeks, you're going to end up in an emergency department as your other option. So again, the doctors are saying, but it's better if you come to a doctor. And the women are saying, I'd rather go to a pharmacy. And they're trying to pull all of these things back. Yeah, I think you're right. If there were a group of doctors in space watching this webinar right now, they'd think they were listening to their medical colleagues talking about healthcare. Yeah.
Okay.
And it's the right person with the right skills at the right time for the patient is what we should be doing. It's not the hat you wear, it's the skills you bring to the table. And pharmacists have it in spades. So we should stop fighting about who does what and just care about the patients.
Yeah, I like that. Mitch, I think, really got the ball rolling when we started to talk about access. And that's really good examples there that we're getting from Paula and from Sham and from Lisa about people's ability to access the physical medicines when it happens, because, you know, we physically exist and the network exists. I know Lisa was also talking about our ability to operate a cold chain, because I know certainly the experience from around the world is that DHL can't operate a cold chain as well as the community pharmacy network can. So what I'd like you to do, Mitch, as well, is I'd like you to talk a little bit about not just access, but about choice. And what does choice mean for the delivery of healthcare through community pharmacies, not just co-administration of vaccines? What does choice mean in your experience in community pharmacy in the United States? Because I think your system can be a little bit unique, because there can be a little bit of patient direction because of insurers and that, or maybe I'm on the wrong beam there.
Great point. That's one of the challenges, even after all these years, that we're still facing, is the directing of patients to certain providers. And I think, I can't remember if it was Lisa or who on the panel mentioned it, that we're our worst enemies when we undercut ourselves. There's enough need out there that we don't have to do that. We need to promote the services and really the value. I mean, I think one of the things that I'm optimistic about coming out of COVID is that we have established an expectation for the public, at least in the United States, when we really had the rush of COVID and we had to go to an appointment-based model for the delivery of care. That's significant, because patients don't go into a physician's office and just walk in. They make an appointment and they see value of that. And so in pharmacy, we need to look at that as well, to give the public an understanding. We're going to give them our attention. We're going to give them the focused services that they need. But we also have to be able to prepare for it and provide that. And so while we are the most accessible healthcare providers in the community, we also need to look at ourselves as professionals. And not say we do away with walk-in, but that we get the patients used to, making an appointment to get our one-on-one time, and to value that the same as, like I said earlier, provision of vaccines is the same no matter if it's a physician doing it, a nurse doing it, a pharmacist doing it. And one of the values that pharmacy provides as well is we go out into the communities, and we're not staying within the four walls of our practices. And so that's significant. And that's something we need to play out as well, is that access point, and having that access point, and the importance of having community-based providers like community pharmacies available for the next pandemic. And this is our opportunity to address what we see as shortfalls in other services, whether it's the dispensing of medications. And in the US, unfortunately, we're challenged with bad business practices by third-party payers that are impacting community pharmacy and other pharmacy sectors. That has to be addressed if we're going to be there for the next public health crisis. They're seeing the value of our access. Now's the time for us to play that out, to get the decision makers, before they move away from thinking about COVID, get that put in place so that we're coming out of COVID in a stronger position than when we came into it.
Yeah, I like that, because that's the experience from around the world. It doesn't really matter. Well, it does matter, but as we see the ability for pharmacists to go above and beyond in serving their communities has put us in a much stronger position to actually have those conversations. And as you will see with the guidelines that we have from FIP, and also the data that's being collected by the Global Observatory within FIP, that we can see we're in a much stronger position to say, hey, hang on a second, this isn't just about vaccination. This is actually about what we can do to lend more value into the service. To bring this a little bit more specifically back to the topic and the title that we're talking about here, which is co-administration, I have another question in, and I might get Paula to start off on this one, and I'll just read it out. The COVID-19 pandemic is slowing down and changing across the globe. How do you think the relation between pharmacists and COVID-19 vaccination will change in the future? And how can this specific vaccine be integrated into future pharmacy-based vaccination plans, considering the annual influenza season, for example?
So first, in Portugal, we hope that pharmacies can be involved in the process. I think, and according to the scientific information, it seems that everything indicates that in the future, vaccination against COVID-19 will be seen as a flu vaccination, a seasonal vaccination, of course, with the guidelines of each country and the availability of the vaccines. But I think in the future, it's going to be seen as a routine vaccination. And we hope that can be integrated in our vaccination plans in Portugal, and the pharmacists can contribute with their expertise in vaccinating for many years in this process. I think
that's a very good answer. And I think on that kind of, uplifting idea of that, of what we've proved, we're running out of time. I could talk about this all day, and I see the wrap up and conclusion coming. So the last one that I'm going to put to each of you very quickly is, and I'll start with Sham, and then we'll go Lisa, Mitch, Paula, and me. And the question is, what would be a key message for all pharmacists around the world about promoting vaccination and vaccine co-administration? In a nutshell, Sham, shoot.
Yeah, I think the first point is getting them to understand that vaccines help prevent outbreaks and reduce burden on an already strained state, especially for us in Africa. We struggle with that. And then pharmacists are important vaccine ambassadors, and they have the ability to influence through engagement and through education. Then utilizing the data across that we've already produced across FIP, for example, is a good way of Portugal, for example, solving their problem. So I think that discussion needs to happen. And the last point is don't allow a missed opportunity in the co-administration space, because you could really save a life there.
Excellent. Lisa.
Yeah, just off the back of Shams, I think also the vaccine is something across a lifespan. That we invest a lot of energy in childhood vaccination, and then we just seem to suddenly revisit it when suddenly you're over 65. But there's a whole lot of vaccination that happens between sort of when you finish primary school and when you're 65. So remembering that it's a lifespan conversation. So the 20-year-old that's coming in needs just as much of the conversation about vaccination as anybody else. And also that every pharmacist is an advocate for pharmacy vaccination for the profession. And so when it does come to those opportunities in countries that are emerging in vaccination, just as it becomes an opportunity to vaccinate, like for us, when it was for pilots and it was an emerging professional field, just because you don't want to do it yourself, as somebody who maybe didn't train to do it originally, and it's a post-grad option, and I'm not sure I really want to do it, you can still be an advocate for the rest of the profession to do it, and an advocate for pharmacists to be an interface for vaccination for the profession. So just because it's not for you doesn't mean it's not for the profession, and to remain an advocate for the profession to vaccinate.
Wonderful. Mitchell.
A couple of points that building off of Sham and Lisa's comments is that we all have a role to play, that no is not a terminal answer, that we as pharmacists are ready, willing, and able to serve the public health needs of our communities, that each of us are public health champions, and that influenza vaccination is not an end, but just the beginning for the role that we play in public health initiatives. Okay,
Mitchell, thank you. Paula.
Yes. So to promote vaccination, the pharmacists should inform the population, in particular the individuals that belonging to risk groups. They need to talk about the vaccine preventable disease and their consequences, the benefits of the vaccination, who should be vaccinated and when, clarifying myths about the vaccination. There are a lot of myths about vaccination. It's also important to promote health literacy, giving accurate, up-to-date and credible information to the population. And the pharmacy is very easy to identify people belonging to the risk groups and advise them to medical consultation for a possible prescription of one or more vaccines, because the age and therapy of the patient allows an easy identification of these people in the drug dispensing process. So encourage them and whenever possible to give the co-administration for their convenience. I think these are the major aspects to promote vaccination in pharmacies.
Brilliant, thank you very much. My own wrap up and conclusion with this is that I feel such a strong message coming from pharmacy advocates and champions that we have here today. We've learned a lot and worked really, really hard under very trying circumstances in the four corners of the globe as community pharmacists, as team leaders to fight COVID. And I think we did a really, really good job, and we all went above and beyond what we needed to do. We kept our doors open, and we were the point of contact that our communities needed when they needed to see a human being and a face. And I think we can be really, really proud of that. But the other thing that I would stress with that is there's no going backwards to a more subservient role than the one that we had. We have the proof, we have the data to show who we are, what we can do. And I think most importantly, the greatest champions for community pharmacists are the patients that we serve. So what I would like to leave us with is that to go back to that idea that Mitch espoused and is in the Community Pharmacy Vision 2025 is it's about patient choice and it's about patient access. And we are there for those people. So in a conclusion, this is an FIP event. So if we can bring up the last slide, then what I'd like to be able to say is we're having our World Congresses coming up very soon in Seville. I know lots and lots of people will be there. Unfortunately, lots of people can't make it because we're coming out of COVID. But there are going to be lots of access to the things that are going on there as well, virtually, either live or to be able to come back to it. And please, 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 if you're not already a member of FIP, please join us and please use the resource that you have to be able to tap into pharmacy champions, advocates, plus other pharmacists and pharmacy team leaders around the world, just like you. So you can follow it through events, as you can see here from FIP, but also more in the round as well, is that the resources that are available through the FIP website are really amazing. You'll be able to look back at sessions like this as well. So I really encourage you to do that as you're continuing professional development. And also for a little bit of headspace, it's very nice to be able to talk pharmacy with other pharmacists. So in conclusion, I want to really thank fantastic contributors, Paula, Mitchell, Sham, and Lisa, and also the really fantastic team at FIP for just making the whole thing run smoothly and allowing us the opportunity to have a really positive conversation around the good work that we do, and that co-administration is here and it's real and we're going to drive it on. Thanks everyone. Have a great day.
Thank you. Bye.